Hello, everyone. Welcome to Workshop 32, Innovations and Challenges in CF Healthcare Delivery. My name is Jennifer Goralski, and I'm from the University of North Carolina at Chapel Hill. My co-moderator is Dr. Christopher Siracusa from Cincinnati Children's. He couldn't be here today, so he recorded a brief intro for you. I do want to point out that our workshop is going to run slightly differently than other workshops. We are going to play all the videos back to back and then have our live Q&A session at the end. Please continue to put your questions in the chat, and we'll be happy to answer them at the end. Enjoy the workshop.
Hi, everyone. Welcome to workshop number 32. Innovations and Challenges in CF Healthcare Delivery. My name is Chris Siracusa, and on behalf of my co-moderator, Jen Goralski, we'd like to welcome you to today's workshop. I believe today is Friday, November 5th, and it is the end of our virtual North American Cystic Fibrosis Conference. So whether you're watching this on Friday or you're watching this later on in the month, we hope you've had a great conference, and we hope you've learned a lot, and thanks for sticking with us. We've got a couple of disclosures to talk about today, although not a lot related to this presentation. Dr. Goralski does have some grant support from the CFF and the NIH, as well as some consulting support for the CFF and Polarian, not related to this presentation. I have some grant support from the CFF and the Boomer Esiason Foundation and some consulting support from Vertex. Again, nothing related to this presentation. I do want to disclose that I have collaboration with Dr. Feligno, who's our fourth speaker today. I did recuse myself from evaluating her abstract before it was chosen for this presentation, though. So it's not new information that the COVID-19 pandemic has drastically transformed the way that we've had to deliver medical care to people with CF over the last 18 plus months. Care innovations such as telemedicine have made access to care easier for many. However, the pandemic has also exacerbated many care disparities, such as food insecurity, inequality in leave policies, as well as access to mental health care. This specific workshop will explore creative solutions to breaking barriers in CF care access and encourage CF care team members to consider advocacy as an increasingly important aspect of healthcare delivery. The presentations in this workshop will discuss topics ranging from international practices and patterns to local innovations. We're really excited for this group of speakers that we have today. Our educational objectives this morning, first, is to estimate the burden of undiagnosed and undertreated CF in low-income countries compared with HIV. Second, identify novel solutions for enhancing access to subspecialty care and life necessities among CF patients. And third, describe federal involvement of the CF community in advocating for expanded paid leave. Our format this afternoon, we are going to have 5 speakers. We will have 15 minutes of pre-recorded talks. And following those 15-minute pre-recorded talks, we will have a about 20-minute live Q&A panel with all of our speakers. Again, this will be live. We are going to ask that you submit your questions ahead of time, if possible, either through the app or through whatever means you have been submitting your questions thus far. Sorry, we don't have more information at the time I'm recording this. There will also be the ability to submit these questions live via the chat. And we hope that you're able to participate and get your questions answered. Again, we're really excited for our 5 speakers today. We had a lot of great abstracts that really highlighted a lot of the things that we wanted to focus on during this session. And we really did pick what we felt was a great swath of sort of the best of what covered the majority of what people were submitting, as well as what we thought people could learn from the most. So our first speaker this afternoon will be Jonathan Guo, and his talk will be worldwide rates of diagnosis and effective treatment for cystic fibrosis versus HIV/AIDS. That will be followed by Karen Carey, What COVID Taught Us, Collaboration in Pursuit of Expanded Paid Leave. Our third speaker this afternoon will be Juliana Bailey, Food Insecurity in the Cystic Fibrosis Care Center Network during COVID-19, Prevalence, Screening, and Interventions. Our fourth speaker this afternoon will be Dr. Stephanie Feligno, Increased Access to Mental Health Care with CF Team Psychologists through Telemedicine during COVID-19. And our final speaker this afternoon will be Dr. Kelly Mason, Improved Referral Rates for Abnormal Oral Glucose Tolerance Testing after development of a multidisciplinary pediatric cystic fibrosis endocrinology clinic. Thank you so much to all of our speakers who have dealt with the flexibility of changing this conference to a virtual meeting, and we look forward to hearing all of your talks this morning, and here we go.
Hello, everyone. My name is Jonathan Guo from the Faculty of Medicine at Imperial College London, and today I will be presenting our study titled Worldwide Rates of Diagnosis and Effective Treatment for Cystic Fibrosis versus HIV/AIDS. So before we get going, there are no relevant disclosures for this presentation. As I'm sure you're all aware, time has seen management for CF advance drastically, most recently in the development of CFTR modulators targeting the root cause of the condition. 4 such treatments are currently licensed and sold by Vertex Pharmaceuticals. The most recent of these, the triple combination of ivacaftor, tezacaftor, and elexacaftor, also known by the brand name Trikafta, is suitable for a larger proportion of mutation profiles and has shown significantly improved outcomes compared with previous generation dual therapy. Due to its increased efficacy and patient eligibility, Trikafta currently represents the best available pharmaceutical treatment for CF. List prices for CFTR modulators have been set between $270,000 and $310,000 per year. Their cost means that even after regulatory approval, the medicines remain functionally unavailable to patients unless reimbursed by government or health system authorities. Even still, the high list prices for CFTR modulators pose resource allocation dilemmas to even the most robust of health systems. As such, even after regulatory approval, patients can still be left waiting years to receive treatment, pending pricing negotiations. For example, in 2018, 3 years after the licensing of Orkambi, only 7% of patients in Canada were receiving treatment. The benefits of CFTR modulator therapy are so profound that such delays cause very tangible impacts on patient outcomes. For example, recent research has indicated universal introduction of Trikafta in 2021 would reduce the number of people living with severe lung disease by 60% and deaths by 15% by 2030. With these benefits halved if introduction was delayed to 2025. Despite this, there exists relatively little literature concerning global patient access to these transformative therapies. CF has traditionally been thought of as a disease affecting exclusively Caucasians of European descent, and therefore only prevalent in Europe, North America, and Australasia. Recent evidence shows the disease is also present in all other regions of the world, albeit generally at lower rates. However, due to this existing preconception, it is almost exclusively high-income countries in North America, Europe, and Australasia, where there are established systematic CF patient registries. Consequently, little is known of the epidemiology of CF outside of these regions, and this is reflected in contemporary estimates of population size. Therefore, in order to define where needs are not being met, it is first necessary to characterize the global disease burden. With the aim of ending the global epidemic, the WHO has set targets for 95% of people with HIV/AIDS to be diagnosed, and 95% of diagnosed patients to receive triple combination antiretroviral therapy, which represents the best available treatment. Progress in this therapeutic area is often displayed via the treatment cascade framework, depicting the proportion of patients diagnosed and treated worldwide. This framework has since been used for other conditions such as TB and opioid addiction, and so could be applied to CF to highlight disparities in diagnosis and treatment access. Therefore, using the precedent set in the case of HIV, our study aimed to find gaps in CF diagnosis and treatment access. This was to be achieved via construction of a treatment cascade to present a novel characterization of the epidemiology of CF. This involved generation of point estimates of the total global CF population, proportion diagnosed, and the proportion treated with the best available therapy, or currently Cftr. A total of 158 countries were included in our analysis. Countries with a total population of less than 1 million and no patient registry were excluded, as there was unlikely to be a significant patient population or available data. In generation of point estimates of undiagnosed and diagnosed patient population, we used a multimodal approach. The highest standard of epidemiological data in CF comes from national patient registries, and so the most recent publicly available data was extracted from all CF registries. Where registries did not exist, PubMed literature searches were used alongside an international survey of 51 CF experts and patient organizations conducted via email communications and virtual interviews. To estimate the number of undiagnosed CF patients, registry data detailing estimated patient coverage was used to extrapolate the total expected number of patients within each country. If this was given as a range rather than a specific percentage, the midpoint of the lower bound and 100% coverage was used. Results for 38 countries were generated through this method. In addition, cross-sectional analyses and epidemiological studies estimating national CF prevalence were extrapolated to generate expected CF patient numbers in 8 countries where data was available. And finally, results for 3 countries were obtained via the CF survey. In estimating the diagnosed patient burden at a country level, results for 45 countries were obtained from national registries. Data for 31 countries were obtained by literature sources. These included previously aggregated regional data, surveys, or case reports of patient numbers in individual countries. And finally, data in 18 countries were obtained via the CF survey. All patients included within country-level data were registered within their respective countries' health systems. Diagnosis was performed using sweat testing as a minimum, and in some cases, genetic analysis was used instead. Information on the number of patients treated with Cftr was not publicly available. Therefore, to estimate this value, sales revenues were extracted from Vertex's 2020 end-of-year earnings report. Only fourth quarter revenues were included to ensure greater accuracy, since regulatory approval in several markets was achieved mid-year. Proportions of Vertex's revenue by geographical region were calculated for the last 3 years using data published within the company's annual SEC filings. An average was taken and applied to 2020 revenues to estimate the proportion of revenue from each region. Following this, the lowest price available within each region for a 3-month treatment course was determined through public pricing databases and used to estimate the number of patients receiving triple therapy. A further 25% discount was assumed resulting from negotiations with payers. And so the undiagnosed CF population was estimated to be 50,800 people. Coverage statistics reported by registries in North America and Western Europe indicate that in these regions, over 95% of people with CF have been diagnosed. Most of the undiagnosed patient burden was located in India, where several estimates of CF prevalence had been made, many of these analyzing populations of Indian migrants in countries with registries such as Canada, the UK, and the USA. Extrapolated estimates indicated a CF patient burden of around 31,500 patients in India. Our analysis estimated 106,000 people from 94 different countries have been diagnosed with CF, with a widespread global distribution. By continent, the largest patient populations were found in Europe and North America, with 47,600 and 37,000 patients identified respectively. There were 11,000 CF cases diagnosed in South America, 5,300 in Asia, 3,600 in Australasia, and 1,600 in Africa. While patient burden is significant in the quote-unquote established regions of North America and Western Europe, our study shows that there are many countries outside of these regions with equivalent patient populations. To focus on a specific example, in Latin America, there were 11,000 estimated diagnosed patients in 8 countries. Most of these patients were found in Brazil and Argentina, where registries do exist but lack the robust coverage of those in North America or Western Europe. In most other countries, efforts had been made to quantify the CF patient population, albeit not formally through registries. In contrast, only 6 countries around the world had agreed to reimburse Trikafta by the end of 2020. These were Germany, Denmark, Slovenia, the UK, USA, and Ireland. Our model estimated 15,000 patients in the US and 4,300 in Europe, with a total estimate of around 19,500 patients receiving treatment with triple therapy at the end of 2020. And so UNAIDS estimates that 38 million people around the world are currently infected with HIV/AIDS. Of these, 31.6 million know their status, and 27.5 million are receiving antiretroviral triple therapy. Consequently, of the entire HIV-positive population, 84% are currently diagnosed, and 73% receiving the best available treatment. By comparison, our analysis estimated that at the end of 2020, of the 157,000 people estimated to have CF worldwide, 68% were diagnosed and only 12% were receiving triple combination therapy. And so to summarize some of our key findings, our analysis shows a significant patient population exists outside of Europe and North America, where the manufacturer Vertex have largely not sought approval for any CFTR modulators. In many low and middle income countries, rates of CF diagnosis remain low. And finally, at the end of 2020, treatment uptake for Trikafta was very limited, at an estimated 12% of the global disease burden. Our study presents novel estimates of the global epidemiology of CF, with a wide variety of countries included. 90% of the estimated diagnosed population were identified from CF registries, meaning a baseline of around 96,000 patients obtained from the highest available standard of data. Data used in this study were extracted from a variety of sources, including communications with CF professionals, conference proceedings, and scientific literature. This multimodal approach provided up-to-date information in areas lacking robust reporting infrastructure. One of the main limitations of our study was a lack of high-quality epidemiological data, in many cases being either incomplete or simply unavailable. For example, no diagnosed patient data was available in 64 countries. This was exacerbated by underdiagnosis of CF in low and middle income settings due to barriers such as a lack of diagnostic equipment and ascertainment bias, where a lack of awareness may lead to misdiagnosis of CF by clinicians. Therefore, these introduce a high level of uncertainty and mean it is likely the final figure for the global CF population is a significant underestimate. As such, more diagnostic infrastructure and epidemiological studies are needed to prevent patients in such regions from being neglected. In recent years, there has been increasing recognition of the need for additional CF research and awareness in LMICs. However, there is little incentive for governments and health systems to improve this in the absence of meaningful treatment options, and so the two are inextricably linked. One other question which remains is if this class of medications needs to be so expensive. Within the literature, estimates have been previously made for minimum costs of generic production for a variety of other pharmaceutical agents. And in Argentina, generic versions of Orkambi and Symdeko are currently available for a fraction of US list prices, despite limited volume demand. As such, a similar estimation of minimum costs of CFTR modulator treatment could allow evaluation of the feasibility of improved global access. In the past, we've seen similarly prohibitive drug prices for HIV treatment decrease by over 99%, a reduction thought infeasible at the time of their first synthesis. The major factor limiting global access to CFTR modulators remains their high cost, even in countries where diagnostic and health system infrastructure reaches the highest of global standards. Therefore, if this is to be improved, urgent action is needed to bring prices down. Antiretroviral treatment for HIV remains one of the greatest success stories in contemporary public health, providing innovative, life-saving medications in even the most resource-poor of settings. It provides a framework of interventions resulting from years of patient advocacy and international collaboration which could be adapted to recreate this success for CF. Similarly, a robust international network of clinicians and patient communities exists for cystic fibrosis, whose collective actions have seen the development of entirely novel therapeutic agents, which now represent an unparalleled opportunity to transform the lives of countless children and families around the world. And so to conclude, A substantial disease burden for CF exists in jurisdictions where the best available treatment is not available. If the precedent set by previous generation CFTR modulators is followed, the high cost of Cftr could delay access for years in high-income countries, while in lower and middle-income countries, reimbursement by government authorities may simply be infeasible. Alongside this, the paucity of epidemiological data and systemic underdiagnosis in LMICs remains a key barrier to effective and equitable treatment. If rates of diagnosis and treatment for CF could equal HIV/AIDS, there is the potential to treat over 100,000 patients worldwide with triple combination CFTR modulator therapy. As such, lessons can and must be learned to recreate the successes of HIV treatment access in order to create a future where the benefits of CFTR modulators are delivered to all those with cystic fibrosis, regardless of their country of birth. Thank you very much for listening. I'll be happy to take any questions now.
Hello. The title of this presentation is What COVID Taught Us: Collaboration in Pursuit of Expanded Paid Leave. My name is Karen Carey. I'm a senior specialist within Health System Innovation and Navigation at the Cystic Fibrosis Foundation. My pronouns are she, her. There are no relationships to disclose related to this presentation. Today, I have the privilege to shine a spotlight on a different sort of challenge the CF community faced with the onset of the COVID-19 pandemic, and to share the process of how a tremendous collaboration turned into a robust effort to advocate for expanded paid leave on behalf of and alongside the CF community. I'll start with a quick introduction, provide some brief context, then get into our methods of review and actions taken, and finally offer a hopeful glimpse down the road ahead. Now, up until May of this year, I was a Cystic Fibrosis Foundation COMPASS Senior Case Manager. For those who may not know, COMPASS is a program within the CF Foundation's Policy and Advocacy Department that provides personalized information and resource referrals to people living with CF, their families, and their providers. In the spring of 2020, like many others, I packed up my laptop, closed my office door, and became a COMPASS case manager from home. Here's a quick look at that home office and how things genuinely felt circa mid-March 2020. But importantly, it's from this area of expertise that I get to speak to you today. My experience as a COMPASS case manager, lucky enough to be working at my dining room table, taking calls from people across the CF community as they sat at their own tables, looking for resources, trying to figure out next steps. Our objective today is to highlight the collaborative efforts involving different parts of our policy and advocacy department, away from COMPASS to advocacy and government affairs, involving the CF community nationwide and numerous external stakeholders in the single pursuit of expanded paid leave for vulnerable populations for COVID-19 or their at-home family members. And it is this sentiment right here that is at the heart of that collaboration. For some background, and going back in time to the spring of 2020 admittedly elevates my heart rate, but let's remember a time for a second before it all. In the year before the COVID-19 pandemic, 52.6% of adults with CF were employed full or part-time. That's from the Cystic Fibrosis Foundation Patient Registry 2019 Annual Data Report. When COVID hit the United States in the spring of 2020, Congress tucked a provision in the Families First Coronavirus Response Act that expanded the Family Medical Leave Act, or FMLA, to include employees with certain childcare complications due to the pandemic and to provide them a percentage of their salary. However, this newly expanded and partially paid FMLA eligibility did not include vulnerable populations for COVID-19 or their at-home family members. The initial response was plainly insufficient for people living with CF and their families. Through calls to CF Foundation COMPASS, many members of the CF community, including working adults with CF and loved ones of people with CF, expressed concerns about a perceived choice: stop working or risk possible exposure to COVID-19. An impossible choice, really, when framed in the context of a person's health, their child's health, their loved one's health, or their livelihood. Now, in ordinary and extraordinary times alike, COMPASS case managers provide callers with personalized information and referrals. When members of the CF community called COMPASS in 2020, case managers relied on a pandemic-bolstered toolkit to connect CF community members to the resources they needed. This included referrals to legal experts, national resources, state resources, and local resources as available to help callers navigate complex challenges with their employers, to answer questions about FMLA, and to help address workplace accommodation concerns. On that note, another widely referred to tool was a workplace accommodation template letter that could be customized with the help of a provider to explain CF to employers and make the case for ways to reduce the employee's risk of COVID-19 exposure to protect themselves and their loved ones. Through COMPASS, these types of information and resource referrals offer benefit to individual callers, to be sure. But as more and more members of the CF community called COMPASS with workplace inquiries, it was evident that case-by-case referrals were simply not enough for the CF community. Advocating for expanded paid leave was needed on a larger scale. With regard to method and actions taken, we reviewed COMPASS call data from January 1st through December 31st, 2020, looking for trends related to workplace issues. The goal? To quantify the lived experience members of the CF community had shared with case managers during the same time. The result? Of 974 COMPASS calls in 2020, during which the caller discussed concerns related to COVID-19. 145 had specific questions about workplace accommodations. 66 had questions about FMLA. That was a 339% increase in workplace inquiries over the previous year. Due to the high volume of COMPASS calls regarding workplace challenges during the pandemic and insufficient federal action in the congressional March 2020 coronavirus response, the CF Foundation and members of the CF community began advocating directly to Congress about the needs for expanded paid leave. With the help of the CF community, a coordinated advocacy campaign was launched in April 2020. So as calls were coming into COMPASS, advocacy and government affairs colleagues at the CF Foundation were alerted, and a collaborative effort to identify and amplify voices within the CF community began. Using an online story bank tool and introductions from COMPASS, as well as from local CF Foundation chapters, more than 75 stories from the CF community were collected. An appeal was also made to CF care providers in states with important congressional considerations for their perspectives and examples of patients who would benefit from paid leave. These stories humanized complex policy discussions and brought the needs of the CF community into the spotlight. The Advocacy Campaign began with a letter the CF Foundation led to Congress, calling for the expansion of paid FMLA to vulnerable populations and their working household members during the COVID-19 public health emergency. A large-scale collaboration in and of itself, the letter was signed by more than 160 diverse patient and consumer organizations. Stories of real-life experiences were shared in numerous ways with policymakers, often directly by the person impacted. For example, a virtual briefing that focused on the public health impact of expanding paid leave during the pandemic featured the testimony of an adult with CF who spoke of the importance of having a paid leave policy that included her. Adults with CF and CF care providers took part in 17 Senate meetings and 2 constituent House meetings. Even teenage members of the CF community asked members of Congress to support the expansion of paid leave, with nearly 80 personal videos created through the CF Foundation's 2020 Teen Advocacy Day. By the end of September 2020, more than 31,000 electronic messages had been sent to members of Congress as part of a months-long grassroots effort. With the new Congress and administration in 2021, the likelihood of seeing such a policy enacted rose. On March 11, 2021, the American Rescue Plan Act, or ARPA, was signed, and federal employees were given up to 600 hours of paid leave to recover from COVID-19, to quarantine, or to care for a sick family member or child who is attending virtual school due to the pandemic. While a major win for federal employees, this provision of the ARPA did not apply across the employer market. Expanded paid leave is still not available for every person with CF or family member during the pandemic. However, this year-long advocacy effort and efforts of numerous external stakeholders helped keep expanded paid family and medical leave at the forefront of policy discussion. We continue to keep our finger on the pulse of possible paid leave policies that stem from the broader discussion. As an example, in the second quarter of 2021, the CF Foundation joined a multi-stakeholder working group led by the National Partnership for Women and Families to look at paid leave policies and what might be included in the next major spending package. The CF Foundation also signed a letter in mid-August asking congressional leadership to ensure that people with medical issues are considered in any paid leave proposal. As of mid-September 2020, the time of this recording, creating a broader paid family and medical leave policy was at the top of the congressional majority's agenda. As has been done time and time again, voices from the CF community moved the needle by raising awareness and helped policymakers realize that these benefits are vital to the health and well-being of all Americans, not just those with a chronic health condition such as CF, especially during a pandemic. So appreciate your time today and the chance to share more about the many collaborative efforts that took place to advocate for expanded paid leave. I'd also like to gratefully acknowledge my colleagues and co-authors on this abstract, Teresa Albin, Jonathan Daniels, Aaron Stocks, and Ozzy Cater. My contact information appears here. Thank you again.
Hi, my name is Juliana Bailey, and I'm the Registered Dietitian and Quality Improvement Coordinator at the University of Alabama at Birmingham Adult CF Center. I also serve on the Cystic Fibrosis Foundation Food Security Committee. And today, I'll be talking to you about food insecurity in the CF Care Center network, the prevalence, screening, and interventions. So I have no disclosures related to this presentation. I wanted to start off by giving a little bit of background on food insecurity. And the USDA defines food insecurity as a lack of consistent access to enough food for an active, healthy life. National food insecurity rates in the United States were 11% in 2018, and that increased to 38% in 2020. However, the impact of COVID-19 on the prevalence of food insecurity in people with CF is unknown. So our objective was to assess food insecurity prevalence as well as screening and intervention practices and CF programs both before and during the COVID-19 pandemic. This research was conducted by the Cystic Fibrosis Foundation Food Security Committee. We are a multidisciplinary team made up of people with CF, clinicians, and CF Foundation staff. So we created a 26-question survey designed to address food insecurity screening, interventions, as well as barriers, both before and during COVID-19. We deployed the survey via email to CF Center program directors and coordinators, and we also put it out on the social work and dietitian listservs. And this occurred between February and March of 2021. Then we sent personalized emails to non-responsive programs between May and June of 2021. And we only allowed one response per CF program. And if we noticed that we had duplicate responses, we contacted that program to see which response they wanted us to use. So this is a map of all of the care centers that responded to our survey. We had a total of 134 program responses, and this represented 41 states. So we got a really good spread across the nation of respondents. With regard to the prevalence of food insecurity in CF, in centers that reported an exact rate, the prevalence was 15%. However, about 46% of programs reported an estimate range, and that was most often between 10 and 20% of their patients experiencing food insecurity. We did note that there was a higher prevalence of food insecurity in programs serving pediatric patients, and 19% of programs reported that between 20 and 50% of pediatric patients experienced food insecurity during the COVID-19 pandemic. For changes in food insecurity screening, we found that 86% of centers were screening prior to COVID-19, and that increased slightly to 91% of programs that report screening for food insecurity during the pandemic. We also noticed an increase in frequency of screening. The frequency increased by 12% in the pediatric programs, by 8% in adult programs, and by 11% in combined programs. And to give you a little bit more of a breakdown on the changes observed in food insecurity screening frequency, we created this graph that shows screening frequency before COVID with the dark blue lines and during the pandemic in the light blue lines. And this question gave several options for how often programs were screening, including annually, at quarterly visits, with the social worker and dietitian visit, at every CF clinic visit, as needed, or not screening at all. And you can see here that the frequency of screening for food insecurity at every CF clinic visit increased from 26% of programs to 41% of programs during the pandemic. We also wanted to understand the disciplines who were screening for food insecurity. And we found that the social worker was the most common care team discipline that was responsible for food insecurity screening, both before and during the pandemic, followed by the registered dietitian. There were a few other care team members who were reported as having some responsibility for screening for food insecurity, including the registered nurse, the medical assistant, clinical coordinator, and other unspecified team members. We also wanted to understand the methods by which programs were tracking food insecurity. And you can see here in this purple section, about 42%, so almost half of programs who responded to our survey were not formally tracking food insecurity in any way. 29% reported that they were using the EMR to track, and then 18% reported that they were using an Excel spreadsheet, and 11% reported other unspecified methods of tracking food insecurity rates in their program. So we also wanted to understand what assistance resources were used for food insecurity interventions. And you can see here that people listed things such as community food bank, assistance with other expenses, informational resources. 82% of respondents were using a food bank, and 86% of respondents were using the HealthWell Foundation grant. About half of respondents were using assistance with other expenses to free up more money to purchase food, and half of programs were also using informational resources. Just a little under half reported using grocery cards. And we did find that 85% of centers reported that they were able to provide appropriate food assistance during the pandemic. And some new interventions reported by a small percentage of CF programs that responded included establishing new in-clinic food pantries or a food box program, new ways to give grocery cards to patients, community-based grant funding, as well as new fundraising efforts centered around food security specifically. Our participants did highlight some barriers to providing assistance during the pandemic. As you might expect, respondents said that they did not have access to their in-pantry or in-clinic food pantry. About 37% listed that as an issue. It's likely due to the conversion to telehealth and having less in-person visits during that time frame. 43% listed decreased in-person visits, so decreased contact with patients because of telehealth, and they didn't have the chance to give them grocery cards or things like that they would normally be physically handing patients. 10% of centers reported decreased funding, and 15% reported a lack of institutional support as a barrier to providing assistance. We also wanted to understand how often programs were screening for other unmet social needs, and this included things like housing, transportation, emotional and mental health, utilities, school and education, high-speed internet access, exposure to tobacco smoke. And we found that the majority of respondents were screening for needs related to housing, finances, and internet access. We also discovered that this was usually happening during either the social work or the mental health coordinator visit as part of their annual assessment, and it was typically being assessed verbally. We also wanted to understand the prevalence of some of these other unmet needs that were listed, and 85% reported that their patients were experiencing job loss. 70% reported that their population was experiencing issues with paying their rent and mortgage, and 74% reported that the cost of medications and healthcare were an issue for them during the pandemic. in addition to food insecurity. So in conclusion, the number of CF care centers screening for food insecurity and the frequency of food insecurity screening increased during the COVID-19 pandemic. And I think that this is really a testament to how hard care teams were working to address this issue and really meet the unmet needs of patients during this challenging time. We also found that rates of food insecurity during the pandemic were higher in pediatric programs than they were in adult programs. And while the rapid pivot to telehealth restricted access to in-clinic food pantries, the majority of CF centers were able to provide food assistance through relying heavily on community-based resources. So future directions for our work include a recommendation for standardized food insecurity screening and for formal tracking of food insecurity in CF programs. And we really need this to be able to monitor trends from year to year. We found that almost half of the respondents weren't tracking and therefore could not provide an exact estimate of the rate of food insecurity that was occurring in their center. So we relied heavily on estimates. Other future work will focus on evaluating the relationship between food insecurity screening practices and nutritional status of patients at CF programs. And we also plan to conduct qualitative interviews with affected patients and families to identify opportunities for improving food insecurity and other unmet social need practices and interventions. I wanted to briefly go over some resources that are available that the Food Insecurity Committee has created, and these are located at mycff.org. We have a food security summary that talks about updated food security data, as well as the connection between food insecurity and mental health. We also have a QI quick guide, as well as handouts for clinicians and a handout for patients and families. We also have a discussion aid on food insecurity screening and intervention, as well as unique food insecurity interventions. If you or anyone in your center is interested in introducing some of these more innovative ways to intervene on food insecurity. And then we have a few more exciting things coming in 2022. There's a QI change package that should roll out early next year. We're also going to have a guide on how to start an in-clinic food pantry. A lot of places have asked for that and are interested to do that. And we'll also have patient advocacy tips, as well as a presentation on federal food programs. And finally, I wanted to acknowledge all of the survey participants. Thank you so much if your center responded to this. We really appreciate the dedication of the care teams, and the responses really helped us get a better understanding of food insecurity across the country within the Care Center network. I wanted to acknowledge Kristen Klim, Kim Reno, and Sarah Sapp at the CF Foundation. I also wanted to acknowledge our CF Foundation Food Insecurity Research Subcommittee. It's a group of wonderful people, and we're led by Dr. Gabriella Oates. And then I also wanted to acknowledge Dr. Keith Robinson, because he was the co-lead on this survey project. So thank you so much for listening, and I'm looking forward to your questions and discussion in the live Q&A following this workshop. And if you have other questions that we don't get to, feel free to shoot me an email. My contact info is listed here.
Hello, my name is Dr. Stephanie Feligno. I am a psychologist at Cincinnati Children's Hospital Medical Center, and I am the psychologist that is embedded into the interdisciplinary team of the CF Center at Cincinnati Children's Hospital. I'm also a professor of pediatrics at the University of Cincinnati College of Medicine. I wanted to thank our conference organizers and for the workshop leaders for the invitation to join this great workshop. Today, we'll be talking about increased access to mental health care with me, the team psychologist, through telemedicine during COVID-19. And here are my disclosures. A few of the top line items we'll discuss today are the utilization of my behavioral medicine services, both prior to COVID-19 pandemic beginning and also during the pandemic. Given the workshop focus is on innovations and challenges, we will use that as our framework throughout, and then we'll talk about some lessons learned and some next steps, with the goal being to continue to innovate and to reduce challenges to increase access to care. This was the landscape of the utilization of my service pre-COVID-19, keeping in mind that these are all outpatient-only appointments, being seen in CF clinic in person. And so there's a great deal of variability here. You can see that the average number of visits each month is just a little bit below 20, and that the variability that you see here is based on physicians' PTO schedules, service schedules. The number of kids being sent in each clinic may be different, and I may only see a few of the families during these appointments. Keeping in mind, everything is done in person at this point. The advantages to our pre-COVID model is that our families had easy access to in-clinic interdisciplinary care. We've done this proactively with some efforts to continue to decrease the stigma that can be associated with psychological services, that I'm present for real-time communication, that the embedded model is convenient for families and that they don't need to schedule separate appointments, that I'm present for shared decision-making discussions, and that I'm available for screening intervention for real-time emotional, behavioral, and procedural concerns. And we have been able to work through any space concerns, and I have access to a billing department. So these really were not issues prior to COVID. We had a number of challenges pre-pandemic, and a lot of folks who are providing mental health care services in CF clinics know this well, and that it's challenging to see parents separate from children and teens during these medical appointments, which is sometimes clinically indicated to provide the best care from a mental health standpoint. And what had always been so disappointing for me as the psychologist is that there really was infrequent and inadequate follow-up between CF visits. And we understand, the barriers to why it's challenging for families to follow up after these CF appointments. Many behavioral treatments, including cognitive behavioral treatment, typically take 6 to 15 visits to see improvement. And without that, it's pretty understandable when people are not getting a sufficient dose that they might believe that treatment is not working because it might not really be working, which contributes to further poor follow-up and poor outcomes. And we know all kinds of barriers can exist, from scheduling logistics and playing phone tag with busy families, the time that it takes to get to an additional mental health appointment, all the logistics, missing work and school, the distance and the travel burdens, and then keeping in mind that transportation can really be considered an additional and separate burden from travel, is whether children's, teens, and adults have reliable transportation to these extra appointments. And prior to the pandemic, for CF, we had very little to no telemedicine infrastructure established within the institution. I had been approved for a CF telemedicine pilot that was scheduled to start the day that the hospital moved to COVID precautions. It was intended to support follow-up only with a very specific type of services, not including family without patient present. So it was a start, but then COVID hit, and you can see here that this is the total outpatient visits by month, in person and telemedicine combined. And so the January, February, and March months are pre-pandemic, just to sort of show you where the average number of visits was before that. We have a pretty big decrease in April as we're active crisis planning. We're really proud to see the impressive recovery right back to where we were and a little bit above that in May. And then you can see across the months of the pandemic, the average number of visits with me each month in person and telemedicine is quite higher, up to 60% higher than it was pre-pandemic. You can see when I took my much needed PTO, we had a drop, but then a pretty quick recovery of access to care after that in August. And we were really happy to see that during the holidays, typically we have a lot of no-shows or reschedules or cancels, and access really stayed pretty consistent across the holidays. And then this figure is a breakdown of those monthly visits, those bars by visit type, just to sort of see the pattern. So from January to April, you see a pretty steady decline in the in-person CF visits, and we start to see an increase in the number of telemedicine visits. Around August through November, we started to see an increase in the number of in-person visits, and this was clinically indicated to provide our patients and families with some procedural support during flu vaccine administration. And then you can see that the in-person visits are starting to increase and the telemedicine visits have stayed pretty stable. In order to increase access to telemedicine care, infrastructure is essential. So from the institutional side, we have our Cincinnati Children's Center for Telehealth. They are needed for any consultation and support, pretty much in real time for clinicians and families. This has made a big difference. They also created videos demonstrating use of all of our telemedicine platforms, as well as training. They created medical record templates for us to use in our documentation, and then have been engaged in advocacy at local, state, and national levels. We have had increased and reliable access to technology for the most part. Our institution supported the purchase of more tablets and software for clinicians to use. And the institution also provided support for our medical assistants to help with technology, both on the family side as well as supporting clinicians. However, this has decreased, unfortunately, lately, and it's been something that's been missed. From a divisional standpoint, in behavioral medicine and pulmonary medicine, we had telemedicine super trainers. There was ongoing monitoring of temporary pandemic licensure by our leadership because that was constantly changing. There were EMR shortcuts for streamlining billing, data collection, and then requirements of documentation, which were also changing during the course of the pandemic. And then behavioral medicine has been providing much needed support regarding pandemic temporary licensure and applications for SIPACT, which I'll talk about in just a little bit. So who is exactly taking advantage of the increased access through telemedicine and why? So what I've certainly experienced is that our teens have had much improved access to psychological follow-up. Teens can be seen at school, as this is an approved location if the setting is private and parent consents to treatment occurring in this environment. Our teens do not have to ask for rides because they can do this from their own home. They're comfortable in their house and they don't need to miss as much in terms of classes and activities, rather than spending between travel and parking and getting to the appointment. A 45-minute appointment when you're doing it in person can sometimes be, 3+ hours of investment, where now families can log in, have their 45-minute approximate appointment, and then be back to what they were doing before. Our adults are experiencing less of a negative impact on their work and caregiving for other children, and any adult caregiving responsibilities that they may have. They don't have to ask for rides, and they're saving gas money. And then our parents of young children, who I oftentimes see for coping post-diagnosis and to build behavioral cooperation with the CF daily routine, are finding that telemedicine is less disruptive to their daily schedule because they don't need to engage in travel to the appointment. They are in reducing infection risk, and they can do these visits within the comfort of their home. And we know when we can increase the dose of our therapeutic services, we're increasing knowledge and increasing skill building in lots of important areas that we need. So improving self-management skills, targeting quality of life, as well as some of these modifiable factors, knowledge, and reducing anxiety and depressive symptoms, and building some healthy coping styles, addressing health beliefs, healthy behaviors, relationship quality, helping support parents in their ongoing efforts to provide appropriate monitoring and supervision and involvement, as well as transfer of treatment responsibility as kids get older. In terms of benefits of telemedicine, there's low barrier to entry. And so we see that people are more comfortable scheduling and attending that initial visit than they may be when it's in person, as well as attending more of the follow-up visits. I've certainly seen a marked decrease in the number of no-shows and cancellations when appointments are in the telemedicine format. There's some efficiency to telemedicine because a lot of times you spend your first few minutes talking about how it was to actually get to the appointment, and now we can just get right to our treatment content. There's really important flexibility during times of illness or other limiting factors. Rescheduling can be a little bit easier, and weather does not impact attendance of telemedicine sessions in the way that it did when we're meeting face-to-face. We're reducing waiting room delays and some of those efficiencies. Other support people and animals can be present for these telemedicine visits. We're much better able to reach our rural and underserved families who don't have adequate mental health resources nearby. There's less need for arranged childcare. We can do more of our peer support groups through telemedicine. And we're not in PPE, which means that I'm not in appropriately. I'm not in gown and glove and mask, and neither are patients and families when they are doing telemedicine at home. So we can actually see each other's faces. We can hear each other a little bit better. There's some important cost savings. We may actually increase privacy and confidentiality when people are at home because they're not being seen by other people in a waiting room. They have easier access to snacks, drinks in their own private bathroom. We know that college counseling centers are overwhelmed, and we know that teens may not have cars. And telemedicine also increase access to care for people with mobility-related disabilities. And with consent, we can also bill for appropriate telephone encounters, given that audio-only encounters are able to be billed for when appropriate. Challenges of telemedicine is that it's certainly a new skill to receive your care this way, and it takes practice. We should make sure that we're doing all that we can to set everybody up to have our telemedicine appointments and services be as effective as possible relative to in-person visits. We want to make sure that there's a safe space and intentional time given to telemedicine, that there's a reliable internet connection and making sure that devices are charged. And it takes some creativity to share documents and engage in interactive activities when we're doing telemedicine versus being face-to-face. So in terms of conclusions, these data represent my psychological service and may not represent all. Our CF care model is dynamic, so we're still trying to figure out where the right place is for telehealth. We want to be mindful of stakeholder feedback and outcomes and be responsive to that feedback. We need infrastructure to provide safe and effective care. Telemedicine is not for everyone all the time and for every need. There are certainly ethical considerations for us to keep in mind, and more research is needed to optimize telemedicine services. I included the PsyPact map for psychologists who are wanting to learn more about PsyPact, which is an interjurisdictional state legislature that allows psychologists to practice across state lines once certified in PsyPact. And then I have some resources here as well. So thank you for the invitation, and I hope you found this very helpful.
Hello, my name is Kelly Mason, and I'm a pediatric endocrinologist at the University of Virginia. I'm excited to be here today to discuss the impact of an interdisciplinary pediatric CF endocrinology clinic on referral rates for individuals with abnormal oral glucose tolerance. I have no relationships to disclose related to this presentation. In the first portion of today's discussion, we will review the general benefits of interdisciplinary clinics. We will then discuss the interdisciplinary clinic at the University of Virginia. Next, we will review oral glucose tolerance testing and examine the impact of a dedicated CF endocrinologist on referral rates for those with abnormal glucose tolerance. Then we will move on to the importance of endocrinology referral for individuals with impaired glucose tolerance or cystic fibrosis-related diabetes. Finally, we will identify knowledge gaps and directions for the future. When I initially developed the title of this talk, I used the term multidisciplinary, and then I came across an article that distinguished multidisciplinary from interdisciplinary. The author suggested that multidisciplinary draws on knowledge from different disciplines but stays within their boundaries, whereas interdisciplinary analyzes, synthesizes, and harmonizes links between disciplines into a coordinated and coherent whole. With this information in mind, I subsequently changed the title to reflect the coherent nature of our clinic at the University of Virginia. There are many advantages of interdisciplinary clinics cited in the literature. These include cost effectiveness, improved outcomes, reduced mortality, the ability to address comorbidities that may otherwise be overlooked, and reduction in discordant treatment plans. Now we will discuss our interdisciplinary pediatric CF endocrinology clinic at UVA. This is an image of the outpatient children's clinic. You can see on the left the pediatric CF clinic, and on the side opposite the waiting area, the pediatric endocrine and diabetes clinic. Now, the CF endocrinology clinic is physically embedded within the CF clinic. This facilitates infection control, allows individuals and families access to the same nursing team, enables coordination between team members, and enhances communication between the CF and endocrinology teams. In fact, on the day of the visit, I generally discuss the case with the CF team, allowing an opportunity for input that may be important as I develop a management plan. Because the CF endocrine clinic is adjacent to the endocrinology clinic, we have access to the same equipment used to care for children with all types of diabetes. This includes the ability to obtain a point-of-care hemoglobin A1C level, download glucometers and continuous glucose monitors for those monitoring their blood glucose level, and insulin pumps for those using other types of diabetes technologies. We also have access to registered dietitians and nurses trained to care for children with all types of diabetes. The CF endocrinology clinic allows for coordination between CF and endocrinology visits, which reduces travel and time off school and work for patients and their families. It also enables families to work with a single endocrinologist, facilitating trust and consistency in evaluation and management plans. Now that we've discussed the interdisciplinary CF endocrinology clinic, let's move on to oral glucose tolerance testing, or OGTT. For those who are not closely involved in the testing, OGTT is an annual screening recommended by age 10 in those without a previous diagnosis of cystic fibrosis-related diabetes. However, rates of OGTT across the country remain fairly low. You can see from 2019 registry data that only 67% of eligible children and 37% of eligible adults underwent screening this particular year. Commonly cited barriers to screening include lack of time, lack of appointment availability, lack of symptoms, and fear of needles. Not only is OGTT an important diagnostic tool, but it's also an opportunity for us to prepare individuals and their families for the possibility of developing impaired glucose tolerance, or CFRD, in the future. In fact, in one study, 30% of children and parents felt that the testing helped them to warm up to the diagnosis. It's also an opportunity to provide education. That education should include the purpose behind the screening because we can see from this table, summarizing results from several studies, that many individuals with CF are not aware of the possibility of developing CFRD. And this can lead to feelings of shock or devastation upon learning of the diagnosis. In 2017, our CF Center's oral glucose tolerance testing rate was 43.5%, well below the national median of 61.8%. Recognizing the value of annual screening, the CF team made it a priority to increase our screening rate at UVA and developed a QI project to accomplish this goal. Our CF team established several initiatives, including the following: the development of a trackable data tool, increased patient education, and process improvement to facilitate patient preparation, engagement in planning and decision-making, and to facilitate scheduling and appointment reminders. Through the hard work and dedication of the CF team, the rate of annual oral glucose tolerance testing increased dramatically from a baseline of 44% in 2017 to 81% in 2020, a rate that exceeded the national median of 51.3%. I joined the clinic in late 2017, early 2018. I used the trackable tool that had been developed previously to evaluate Ogtt results and endocrinology referral rates for abnormal results in 2017, the year prior to the development of the Interdisciplinary CF endocrinology clinic, the year it was developed in 2018, and the subsequent year. I analyzed the data over the last year. I specifically reviewed each Ogtt result documented in the trackable tool and categorized the results using the criteria outlined in the table. For the purposes of this project, individuals with only impaired fasting glucose were combined with normal glucose tolerance. I then reviewed the electronic medical record to determine if those with abnormal results, either impaired glucose tolerance or CFRD, were referred to pediatric endocrinology. I included children and adolescents who were followed at our CF Center and were eligible for annual oral glucose tolerance testing. I excluded those who were already followed by endocrinology who would not require a referral to establish care. This is a summary of our data. As previously discussed, the screening rate in our center improved after the initiation of the QI project in 2017. Whereas only 35 tests were completed in 2017, 60 were performed in 2018, and 54 in 2019. The rate of CFRD at our center, depicted in orange, ranged from 6.7 to 11.4%, while the rate of impaired glucose tolerance, depicted in green, ranged from 13 to 20%. We were excited to discover that our endocrinology referral rates for those with cystic fibrosis-related diabetes were 100% in all years evaluated. However, in 2017, at baseline, only 3 of 7 of those with impaired glucose tolerance, or 42.9%, were referred to pediatric endocrinology. In 2018, this rose to 5 out of 9, or 55.6%, with an even more dramatic increase the year after the clinic was established in 2019, when 6 out of 7 individuals with impaired glucose tolerance, or 85.7%, were referred to pediatric endocrinology. So why is referral to an endocrinologist for those with abnormal glucose tolerance important? In addition to the lack of awareness we discussed earlier, many individuals frame their knowledge of CFRD based on experiences of friends and family members with other types of diabetes. We can see here that in one study, 40% of adolescents with CFRD compared their diabetes to other types of diabetes, stating that it runs in the family, or was regular diabetes, or like type 1, or like type 2. In another study, those with normal or impaired glucose tolerance felt that CFRD was no different than other types of diabetes. This underscores the need for additional education regarding the purpose of screening and the pathophysiology of impaired glucose tolerance and CFRD. In fact, there are a lot of misconceptions about CFRD. The following are data from semi-structured interviews of individuals with CF. While many recognize an association with blood sugar or the pancreas or insulin, others felt that CFRD occurred because they weren't taking care of themselves, or that there was a hereditary predisposition, or that eating well was protective. Some parents felt that their children were on insulin solely to help with nutrition, while others felt that the diagnosis of diabetes was unrelated to CF. So in addition to a general lack of awareness, there are also many misconceptions. Annual screening and referral for those with abnormal results allows us an opportunity to raise awareness and correct these misconceptions. In addition, it enables us to initiate appropriate monitoring and therapy for those with impaired glucose tolerance or CFRD. Early intervention may reduce the negative impact of hyperglycemia on health outcomes. It is well established that CFRD negatively impacts pulmonary function, and data suggests the same may be true of impaired glucose tolerance. These are data from a cross-sectional study of 50 adolescents and adults with CF who underwent both oral and IV glucose tolerance testing. We can see a significant reduction in FEV1 depicted in white and FVC depicted in black in those with impaired glucose tolerance and CFRD compared to those with normal glucose tolerance. Similarly, CFRD is associated with a decline in nutritional status. These data from the same 50 individuals with CF suggest that impaired glucose tolerance may also impact nutrition. As we can see, those with impaired glucose tolerance and CFRD had significantly lower body mass indices than those with normal glucose tolerance. These data from 55 pediatric and adult patients support the potential impact of impaired glucose tolerance on nutritional status and pulmonary function. As you can see, BMI, SDS, and FEV1% predicted were significantly lower in those with impaired glucose tolerance compared to those with normal glucose tolerance. Over the last 15 minutes, we've reviewed the importance of annual OGTT, both as a diagnostic tool and an opportunity to provide education and prepare individuals for the possibility of developing abnormalities in glucose tolerance. The introduction of a dedicated CF endocrinologist with coordinated CF and endocrinology visits reduces time and travel for patients and families, promotes trust, and facilitates coordination and communication between the CF and endocrinology teams. However, there are still many questions yet to be answered. For example, when should we begin discussions on OGTT? Should we start at diagnosis, which is now commonly occurring during infancy, or sometime in the years before screening is initiated, or at the time of screening? How often should the purpose of testing be reviewed? Yearly may be too frequent and may result in education fatigue, but discussions should be frequent enough such that individuals and their families remember this information at the time of testing. Finally, who should provide such education? Should it be a trusted member of the pulmonary team or an endocrinologist, such that patients and families have already established care and developed a relationship should they develop abnormalities in glucose tolerance in the future? With that, I would like to send a big thank you to the entire pediatric CF team at UVA. In particular, I would like to thank Dr. Deborah Froh, our CF Center Director, for giving me feedback on this presentation and its multiple iterations. I would also like to thank Rhonda List and Lauren Ahrens, our project champions that helped increase our rate of oral glucose tolerance testing at UVA. I would also like to thank the Cystic Fibrosis Foundation and Emerging Leaders in CF Endocrinology 2 program, specifically my mentors, Drs. Trang Lee and Scott Blackman. I look forward to taking your questions at the Q&A session, and thank you so much for listening.
Hi, everyone. Thanks for sticking with us to the end of Friday. I'm looking forward to a lively discussion here. So the first question is for Jonathan. Could you identify what strategies might be the most effective to improve global diagnosis of CF?
Yeah, sure. So I guess from my perspective, at least, it's really something you have to do sort of from the top down as well. So for example, even in medical school, for example, I can say from personal experience in medical school, I think you got to break down these kind of preconceptions and things which we're finding out more about. So for example, in cystic fibrosis, when we were taught it in medical school, we're basically kind of told still that it's really only something that you see in Caucasians of European descent. And obviously in that kind of pattern recognition style with which medical students tend to learn for diagnosis, I think you can see how at like an institutional level, when that's rolled out and that goes with all the sort of young and upcoming doctors, how that can perpetuate these sorts of ideas. And I think part of that, therefore, is just more advocacy. And obviously, as has been seen in various workshops and symposia at the conference this year, it's a sort of ongoing process. But I think also, sort of from the top down, a big thing is that it's very difficult for clinicians and patients in these sorts of underserved areas. That's in a very hard position because, so for example, I was speaking to a doctor, I think in Kazakhstan, where there isn't that much awareness around the issue. And he basically told me if he has a patient who he suspects has cystic fibrosis, it's very difficult for him, firstly, because there's very little diagnostic equipment. I think he said he had to ship samples for sweat testing or genetic analysis to an entirely different country within Europe for testing. But also because even if that test were to come back positive, there's really not much that they can actually offer in terms of cystic fibrosis. Putting a label on it doesn't really provide any meaningful functional benefit for the patient. And so in that situation, there's very little they can actually do. And at a government level as well, I think it's very difficult because it's very difficult to get people to invest in improving the diagnosis, improving the infrastructure when there is no meaningful treatment or very little meaningful treatment in that sense. And I hope that answers that question to some degree.
I mean, I think to the best you can, right? It's certainly challenging, and there was a really fantastic symposium, Symposium 16, that talked about developing country perspectives in CF care earlier on. So if anyone's still on the call and you hadn't seen that symposium, I highly recommend it. One of the speakers in that symposium used the term modulator migrant, which I found so horrifyingly sad and yet probably true. That people cannot access these drugs in their home countries and are going wherever they can in order to gain access. And so those are even people who have been diagnosed, and you highlight the problem that we see with limited diagnosis in certain countries. So thank you so much for that. The next question is going to go to Juliana. How should CF centers think about addressing screening fatigue?
That's a great question. I know that our patients get so many different surveys now between mental health, depression and anxiety, quality of life, and a lot of places are recommending to screen for food insecurity at every visit. I think as far as food insecurity screening is concerned, the screeners that are validated are very short and they can be done really quickly, even if they are done at each visit. So hopefully the brevity of the food insecurity screening will hopefully help to combat the screening fatigue. Otherwise, I think also just partnering with your patients, and if they're telling you like, hey, I'm sick of doing this at every visit, could we maybe do it like once a year, and sort of tailoring your screening methods based on what you're getting from your patients could also help with that screening fatigue.
It's true. Sometimes those things come out just in general conversation with the patient that you don't necessarily need to do a screener to identify these issues, right?
Exactly.
Also, certainly it helps with our data collection, our ability to go back and review these on a more global level. But yeah, from the patient's perspective, it does make sense not to sort of reiterate the same thing. I actually had a question for Karen. I was curious about your, what an amazing effort regarding advocacy so early on in the pandemic when we were dealing with so many different things, right? So I really applaud you and your team for tackling that. And I'm curious how you have either seen it change or anticipate that it might change as vaccines rolled out and now as they get thankfully extended down into younger children, if that's going to be a hindrance to ongoing approval of extended family leave in the COVID era.
Thanks for that question, Jennifer, and this opportunity. April 2020 feels like eons ago, and so much is different today. Wondering about how acute the need may be at the moment, because the pandemic does look a little bit different for some folks. I mentioned in my talk that I was lucky enough to be working from my home. The fact is we know that was not the case and is not the case for everyone. And so I think part of the big picture consideration is just working to get that broader policy applied to more and more people. There are certainly lessons to be learned. And I think the important thing is that the CF community really got this on the radar, and other disease groups have picked up the mantle. As we got into summer and fall of this year, pursuing that broad scale, the base paid, leave that is paid has really taken off, and this community got it to this point. So I think if there's a lesson learned from my policy colleagues is that you got to take the win when you can get it and build upon it kind of bit by bit.
Well said. Thank you. All right. This question is to Stephanie. One psychologist earlier in the week suggested that confidential discussions were more difficult with telemedicine due to other people in the home. Do you have thoughts on this?
Yes, that's an excellent question, because telemedicine, in my opinion, has drawbacks and it has advantages. And one of the things we need to ensure is that people are able to discuss things in a manner that feels confidential and safe, akin to like what they were doing in in-person visits. So, when I'm seeing folks in person, face to face in my office, the environmental things that are very clear is that we have a door that is locked, so that people can't just like walk in from the outside. And there is, in our new building, white noise that is going on, coming from the ceiling somewhere. Ask the environmental engineers. In our previous building, we had white noise machines right outside our door. So when I'm doing telemedicine appointments with folks, I try to think about how can we make sure that you're set up in that similar way in your home. So I always ask things like at each appointment, like, who's home with you today? Mm-hmm. Who of those people are in support of you having a therapy session today? Who is not in support of you having that therapy session? Have you had any discussions about whether people can knock, whether they can just come in? Do you have a sign on your door? Is your door locked? Do you have a white noise kind of option? And so I think you'll hear from me when I get lots of great questions, is it all depends. It depends on how we set things up. And it's really important that we encourage patients and folks who are receiving therapy to feel like they have a very similar level of privacy as they would in these in-person visits.
Thank you. As a follow-up to that, one of the other attendees had asked about within your profession, what is the thought about ongoing teletherapy availability for patients post-pandemic, when things sort of move back into the clinic for most other specialties? I think that you clearly highlighted a lot of the benefits that we see with teletherapy. And we're wondering what your thoughts are about that.
Again, a very psychologist answer here. So I would encourage, just like I do in therapy, is when we're uncomfortable, we usually want to go, right? So we can either go forward or we can go backward. And neither is necessarily right or wrong. It's more about going somewhere that works. So there were some pre-pandemic things that were working very well. We'd like to continue those going forward. there were some things that were clearly not working very well. We should discontinue those. We should change them. We should improve them. We should swap something in their place. And one of the things that we are so great at in CF is collecting data to make our decisions. And so if we're going to make changes, we should not be making changes based on beliefs. We should be making decisions based on data. So, here are some of the data that I presented today. Mm-hmm. People are accessing this service, but there are some data that are missing. And some of the presenters and other presentations throughout the conference have presented on satisfaction data. Mm-hmm. And I have done some case series presentations for our CF team to say, here are some examples of people who are getting increased psychological care. Here is what is happening to their screening scores. Here is what's happening to school functioning. Here's what's happening to college applications. Here's what's happening with people who have been terrified to drive, who now have their driver's licenses, who are now connected with psychiatry and who are now taking medications and who are doing great in school. Now, not everyone, because of telemedicine, it's not a magic wand. Not everyone's going to be getting better, but I think it's really important for us to continue to share data, get all of the relevant stakeholders' feedback to make sure that we are continuing to partner with our institutional leaders to advocate at local, regional, state, and national levels, especially for parity of both in-person visits, similar to telemedicine visits, similar for mental health codes, similar for health and behavior codes, and that we rely on a combination of both parent, patient, and provider recommendations for which format is best and which format is safest, if it's in person or if it's telemedicine. We have to have sustainability of the financial model for telemedicine to continue to be a way to increase access to care for folks who really need it.
Yeah, absolutely. Thank you for that. Okay, Kelly, for you, they really enjoyed your talk. Our diabetes center is in a different building than our CF center. Would this be prohibitive to having the endocrinologist in clinic, since the testing and other helpful things that you mentioned may not be available, or could they be made available?
So yeah, I certainly don't think it would be prohibitive. I think a lot of this data we can get from other avenues. So, taking the meter and scrolling through and seeing what the numbers are instead of downloading it. There's a venous A1C that could be obtained, to take the place of the point of care A1C. I think the point of care is helpful in the moment because it sometimes can change management. But I certainly think that, it just kind of happened that our clinics were on the same floor and adjacent to each other. But I definitely think that it could work in other scenarios as well.
Do you think there's a role for incorporating the telemedicine aspect?
Absolutely. So we certainly do a fair number of visits by telemedicine. And I think the combination of telemedicine and in-person visits is really important. I think that telemedicine allows for kind of more touch points to sort of emphasize the importance of ongoing monitoring and therapy with patients and their families.
Gotcha. And I'm just wondering if you wouldn't mind delving a little bit more into the tracking tool that you were referencing during your presentation. I was curious, just sort of the logistics of how it works and what you're tracking and how everyone can access it.
Yeah, so really good question. And I don't know that I'm the best person to answer that. It was actually driven by our QI coordinator. So she kind of assessed everybody's OGTT status, and we had their names listed when they had their OGTT, or if they were due and when they were coming due and what the results were. So everybody was allowed to access it and look through to kind of see, which is how I got some of the data that I presented. But she was sort of one of the folks who was sort of in charge of coordinating everything, and I think that was really helpful, and continues to be really helpful.
Is it built into your EMR, or is it a separate?
No, it's an Excel sheet. So it would be fabulous if we could have a tool built into Epic, and that's a really great idea. I think for everybody moving forward, it would be really nice to have some type of system that was integrated into the electronic medical record to track these things.
Yeah, absolutely. Okay, Jonathan, for you again. They were curious if eligibility for triple therapy was taken into account when looking at the total numbers of patients versus those treated. And I would add, as a secondary question that I had, I was wondering if you were going to repeat your analysis moving forward, because if I remember correctly, we really only had Trikafta approval for a couple of months at the time that so you're looking at just the last quarter of 2019. Is that correct?
Yeah, that's correct.
And so if there was sort of more time for people to get in gear and get access to this medication, would those numbers change?
Mm-hmm. Yeah, so I guess on the first point to start off with, obviously, variety of genetic mutations around the world. So huge, great topic. Probably enough to fulfill like another workshop entirely. But yeah, definitely something that we considered. So we didn't actually incorporate that into our analysis itself, but obviously we understood that in LMICs especially, there's very different mutation profiles generally compared to European countries and North America and some North American countries, purely due to genetic ethnic makeup. However, obviously that can vary very much within continents, within even neighboring countries, of nuance and caveats to that we would have to, that we felt like we couldn't necessarily include within the scope of our analysis if we were to include it. So we didn't actually necessarily account for that. And another sort of thing to even with Trikafta and triple therapy, there has been some evidence, I think, that it's still, for a variety of rare mutations, it's still effective. And again, a lot of those LMICs, despite the variation in genetic mutations, in a lot of them, the sort of standard or most common Delta 508s is still the most common. To your other question, sorry, could you repeat that for me?
Sure. I was just wondering if you're planning to repeat your analysis in terms of number treated once we get a little further on, and now we've had it for almost 2 years as opposed to a few months.
Yeah, so I think as of July 2021, to my knowledge, it was reimbursed in around 17 countries around the world. And I think while it's definitely true that given time and negotiations, obviously that rollout will increase, I think one big sort of crux of the issue is that if you look back, for example, to Ivacaftor or any of the older combination Cftr modulators, they had, even though they've been out and sort of approved in various jurisdictions for around almost a decade, some of them, there's still no, I guess, they're still not reimbursed, and they're not even submitted for approval in a lot of countries. For example, in South America, in a lot of countries, and even more so in areas like Asia, the Middle East. And I think, therefore, to some extent, there is an element of whether manufacturers and whether they have the will to submit those and get that moving on that front as well. And so I think it's definitely something we'd like to look at again as the whole situation develops, but not in the sort of short term, I think, because I think it will take some time based on the previous track record.
Yeah, one of our attendees commented that in India, they're beginning to use water-induced finger wriggling to screen, and that was in that symposium, given the problems with diagnostic testing. So great, thank you. For Karen, can you share more about why the collaboration you discussed was so important?
Sure. Well,
as was alluded to in the chat, in general, the big picture thing to remember is that paid leave in this country is provided by employers, not mandated by the government. So companies can and do offer paid leave, but it's not a federally mandated benefit. And so as we kind of talked about previously, but the crux of this was really to ensure that everyone had access to that benefit, especially during the pandemic. And that's really what made this ask and the moment so unique. Kind of to that point of, incremental change is where the win is. It's the idea that there are a lot of external forces at work. And while we can't control much beyond the letter of the policy, for example, with the work around paid family and medical leave, it's important to celebrate that we're a small community, but the policy that this community helped send forth is in the initial laws that have come out of the last 18 months. So it just goes back to that idea of we are a small but mighty group.
Yeah, we've sort of proven that over the years in various different aspects, right? We have one of the most amazing registries for any disease group, right? And are very well regarded in those senses. So kudos, thank you. Juliana, I have a question for you, and this is something that our center has encountered. You had mentioned lack of institutional support, and it's sort of amazing to me that in the question of food insecurity, that there could really even be a question about whether or not having a food pantry or having some other access program embedded within your clinic, it would be a problem from any institution standpoint. But we've certainly encountered it there. The terms that we hear is that it can be seen as being an inducement for the patients to come and get their care from us, and that there's a limitation in how much or what the sort of monetary value of what we provide can be for those patients. And so I'm wondering if your working group has come up with any sort of solutions or ways around this challenge.
I'm so glad that you asked that, because in my center, we also experienced some institutional barriers that we had to really work around. And I think that the great thing about this committee is that we have so many different dietitians, social workers, physicians, even patient family members all contributing from different CF centers across the country. And we've been able to really put our heads together and develop a lot of great resources. And I believe in 2022 is when it's coming along that we have sort of a how-to guide or tips and tricks guide for how to create, an institutional food pantry. And I have not seen the draft of that, but I will certainly, bring up the feedback of maybe how to have some of these conversations with your institution about, working around the barriers, such as the one you mentioned with cost. And, I know in my institution, it was a space issue. Right? Like we could make these food bags to give to our patients, but our clinic space is very limited. We're even limited on clinic rooms. So it was kind of, myself and our social worker, we were running from one building to another in the middle of clinic to grab food bags and bring them over. And, they each weigh like 20 pounds sometimes. So I think that it would be wise for us to include some tips for, working with your institution around these barriers, particularly as people transition back to doing more in-person care. So thank you for highlighting that. And
you are lucky that you're able to provide 20 pounds of food. Our institution has set a hard limit of $15 and a cap. I can't remember exactly, but maybe somewhere around $60 or $90 for the year in terms of what could be considered the value of the goods that we give them. And, it's just sort of,
that's
so
really
we used to have regular food drives and things like that within our research center. And yes, space certainly is an issue, but then moving forward, we have to make sure we're in compliance as well. So.
Right. Yeah, it's an important issue, and I appreciate you highlighting it. It's, more work for our committee, but we're committed to doing it. And thank you for the input.
We look forward to getting those responses back. All right, Kelly, if we are not able to embed diabetes providers in the CF clinic, what other strategies can you suggest to coordinate care and increase access to CFRD care?
So I think telemedicine is, this is a really great platform for incorporating endocrinology through telemedicine as well. And other things, I think some of our pulmonary providers are really comfortable and have time in some of their visits to sort of discuss the same things that we do as endocrinologists. So, I think if you have the time, it can certainly be done in a regular appointment. But I think obviously we're all limited in time and space, as has been shown by multiple discussions throughout the course of the conference. So I think telemedicine really would be advantageous in that particular situation.
Yeah, it's very interesting. We're trying to do a QI project around the same idea at UNC, and re-educating the pulmonary providers about basics of diabetes care. I think that we're all fairly comfortable in an inpatient setting, right? Starting insulin is not a big deal, but the group of us decided, we said, oh my gosh, I would never even consider it, doing it as an outpatient. And in reality, it's not that much different. And so there are some interesting things that one could think about in terms of, is there somebody in your practice that could get, a certified diabetes educator certification, maybe that's a CPP, or maybe it's the dietitian or somebody else, so that at least you can initiate that process, and then rely on the endocrinologist for the more complex cases or the ones that you're having difficulty managing. So that's just a thought that we've been trying to work on our end.
Yeah, no, I think the education piece is really important too. And again, educating providers, but also educating patients. We found, kind of to my surprise, we've actually started a few patients on insulin remotely, which was a little bit scary. But when you're able to do a video conference and actually demonstrate some of the tools, it's actually worked out successfully so far. So I think providing education and spreading that knowledge is really the way to overcome some of the barriers to subspecialty care.
Thank you. For Stephanie, have there been circumstances where poor patients cannot do telehealth due to a lack of resources, and how do you suggest overcoming that?
So my clinical experience has not indicated that our poorer families have had difficulties accessing telemedicine. I think there are a lot of data out there by very big organizations that have found that a lot of people have cell phones, regardless of financial status. So for telemedicine, you need to have a cell phone, number one, and we know a lot of people have cell phones. You also need to have a reliable internet connection. That is probably the place where I've experienced the most difficulties for people not being able to connect at all or connect reliably. However, we can also bill for audio-only sessions that don't require video and use of Wi-Fi. You don't need Wi-Fi, but we don't want to pull from people's data plans unless they have unlimited plans, because of the two-way video really uses a lot of data. So I always make sure that when people are on video that I say, are you on Wi-Fi? Because if you're using data, we need to probably find a different solution. So I think it's incredibly important that we address all barriers to access to care. Poverty certainly can be one of those things. And what we want to do is identify the barriers and do whatever collaborative problem solving that we can do with folks to figure out what might be some other safe private places where we could do telemedicine, where you would have a reliable internet connection. No, some kids are getting laptops sent home from their school districts. Like, could we use that? And as long as it was secure and safe and all of those important things. But I think we shouldn't necessarily make the assumption that poverty is going to be the barrier. We want to do lots of assessment around social determinants of health to help us figure out what barriers to care need to be addressed. Poverty may be one of them.
Absolutely. Well, I saved the best question for last, and it says, this workshop highlights innovations in care delivery. Can each of the speakers provide their opinion on what innovation they would most like to see, develop, or sustain in the next 1 to 3 years in CF care? I said that, and another question just popped in, so I didn't mean to tell our audience that we had to end early, but that was the only one that was left. So please feel free to keep sending in your questions if you have more, but let's go ahead and address that one by one, if you would. So what innovation would you most like to see, develop, and sustain in the next 1 to 3 years of CF care? We'll start with Jonathan.
Yeah, I think, as you mentioned, the Cystic Fibrosis Foundation has one of the world-leading registry systems, reporting infrastructure, and really has kind of led the way in the disease area for decades now. And so I think using that sort of wealth of experience and using the specialist knowledge that comes with that, working in partnership with different institutions in different countries where perhaps that infrastructure is not there, or there's maybe more difficulties in implementing it. I think that is really the thing that I would say. I think using the momentum that's sort of been built up and translating that into actual meaningful outcomes. Yeah.
Thanks. Karen.
We've heard the undercurrents of those social determinants of health. And with full disclosure, I am no clinician, but this idea of addressing the wider set of forces, for example, paid leave, would really be an incredible thing. And I don't think it's going to be tackled in 1 to 3 years, but we should put it on the to-do list as it is on so many people's to-do list already.
And Juliana?
So I think we talk a lot about the importance of screening and food insecurity, but Jennifer, you brought up a really important issue of delivery of food to our patients who are food insecure. And it's kind of a dream big thing, but what I would really like to see is some way that we can get sustainable funding to create a national intervention to maybe give people with CF the opportunity to utilize grocery delivery services. The pandemic had me thinking about that a lot with, not seeing patients in clinic, and they couldn't utilize our in-clinic food pantry. And we were kind of just like stuck, and what do we do? And how can we facilitate this? So that would kind of be like my dream innovation. Again, like Karen said, I don't know that it'll happen in the next 1 to 3 years, but something to aim for.
Yeah, we were afraid of our food going bad during the pandemic, so we scheduled drive-by food drop-offs, right? So people pulled up. We were out there for 2 hours at a time, and people drive by, pop up their trunk, and we put a bag or two in their trunk. It was great. That was before our institutional issues, I should say.
Right.
But
it's amazing to see what all the centers did to, all the individual interventions to get food to patients. And I would love to see some sort of national collaborative effort around this.
Yeah. All right, Kelly.
Yeah, so I really would like to see telemedicine sustained. I think it has so many benefits, as we've seen in a variety of settings and so many applications. And really allows us to provide much more in-depth education and much more frequent education to patients and families than we might otherwise have in a dedicated clinic time slot. So that's something I would like to see. I think we generally, many centers did really well coming up with platforms for this really quickly. And my hope is that we can find some way to sustain that over time.
Great. All right, Stephanie.
Yeah, so I'm just going to follow right off what Kelly's saying, because one of the moments in your presentation when you were talking about people potentially stalling and delaying on the Ogtt because of some of the needle-based procedures, that's one of the ways that people have been accessed, or the reasons why they've been accessing my telemedicine services, is because we've been doing a lot of care plans for supporting the needle-based part of the Ogtt before they've been coming into clinic to get the Ogtt, and we've had some really fantastic successes the last few weeks. So I would definitely advocate for us as all of care team members, patients, families, and the CF Foundation and all of our institutions to be thinking creatively about areas where telemedicine can continue to advance the behavioral health work that we are doing. So, I've even seen a family before they had their child, because they know this baby has CF and they're already struggling with some coping. Mm-hmm. I mean, I've never seen, in the 13 years I've been with my CF center, I've never seen a family before a baby's been born. I mean, this is incredible. I'm seeing more and more families now post positive newborn screen, positive diagnosis to address some of the coping in the first few months of life. We can work so much to build behavioral compliance around neb masks and CPT and taking enzymes, potty training, pill swallowing, adherence around diabetes and other forms of daily care. Certainly we can do mental health around the anxiety and depression and ADHD. We can do procedural support. We can support kind of the behavioral components of nutrition plans and physical activity plans. We can address some of these end of life and palliative care sorts of things in a way that we may not have been able to from an emotional wellness standpoint. So there are just so many areas that we can provide emotional and behavioral support, and telemedicine has increased access to this in a way that we have been wanting for a very long time.
I would echo that, and certainly think that is an ambitious plan for the next 1 to 3 years, but we're going to go with it. I have an even more ambitious plan. I'm not sure they were actually asking for my opinion, but I'll give it anyway, is that I would like to see all of us as CF care centers and the CF Foundation really become a leader in establishing equity in healthcare, particularly as it relates to racial disparities and gender biases as well. And that is something that I think we can definitely achieve in the next 3 years, or working towards it at least, to break down some of those barriers. And we have, as we've noted before, we've been a leader in so many other areas. I think that if we actively work on this, as the foundation has already started, we can make real change that others will follow. So there was 1 or 2 final questions coming in for Stephanie. How are non-English speakers being supported through telehealth?
Outstanding. So I just received a training yesterday. So at Cincinnati Children's, where I am, we just recently finished building a new building. That is our critical care building. We're getting ready to move folks in there today, tomorrow. It's a big move. And so we were trained on the new telemedicine equipment that's going to be utilized in that area. And so one of the new pieces that has continued to be innovated is how we are incorporating whenever we need interpreters. And so I have honestly not had an interpreter present for any of my telemedicine visits during the pandemic, largely because almost all of my families are at home. But even some of the inpatient services that I've provided, I haven't had an interpreter present. I have had an interpreter present in some of our outpatient visits, but those were done face-to-face. So for me, the need for an interpreter is one of the clinically indicated reasons why I come and see people face to face, so that we can use the interpreter in the workplace. But there are some innovations within our hospital to make it easier to just kind of touch the screen and have one of our on-call folks who's doing the interpretation available. And I'm sure lots of other institutions and folks who are attending our conference have more information than I do. But it's a very important question because it addresses the equal access for all.
Absolutely. All right, well, We'll finish up on a nice message from Deborah to Kelly. Yay on your presentation. Way to represent UVA. Great discussion, everyone. I love our CF community, and I will certainly echo that, though I'm from UNC and not UVA. But I would like to thank all of our presenters for such a wonderful discussion and all the thoughtful questions that came in from our audience. We've just got to keep this conversation going. I look forward to hearing progress at next year's NACFC. Thank you, everyone.